Pleasure to be here and to see just a few familiar faces and a lot of new faces, and I look forward to continuing to meet more of you. Thank you, Doug, for the opportunity to come and share some of my insights on anesthesia for in-office procedures. I just want to touch base on my background because it's really relevant if you're looking to get involved with this. I did general ENT for many years, starting practice in 1992. And then, as now, most residencies were really OR-based. You know, we did the occasional biopsy or stop a nosebleed in clinic, but we didn't do anything that would really qualify as a surgical procedure in the office under local anesthesia. Then later in my career, I started doing more facial plastics, and I worked with two different general plastic surgery practices part-time, and I was doing a lot of facelifts and brow lifts and blepharoplasties and liposuction, all under local anesthesia with oral sedation. I kind of had to teach myself a little bit, and it was a tremendous opportunity. And I got pretty good at doing fairly big procedures under local anesthesia. And then after 30 years in private practice, I had this great opportunity to join my friend and colleague, Doug Scarata, say hello, Doug, who opened a new concept called the Modern Nose Clinic. We have clinics in Oregon, two of them in Oregon that he runs, and then I started the one up in Bellevue. And our practice really is an office-based procedure practice. We have in-office CT, and we do a lot of in-office procedures. We do Eustachian tube balloon dilation, we do balloon sinus dilation, we do ethmoidectomies, we have image guidance, we do microdebriders, we do turbinate work, we do endoscopic septoplasty, all under local anesthesia with oral sedation. So the reason I'm telling you my story is that if you don't have experience with this in the past, you can teach an old dog new tricks. You can begin in the mid or even the latter part of your career doing things in the office that you never thought were possible. So the goal today is to give you a few tips that will make that transition smoother, and if you're already doing them, maybe to pick up a few pearls or to offer us a few pearls at the end. So why bother doing in-office procedures? Well, it's been said that the only thing that's constant is change. So your business is either growing or it's shrinking, most likely. And in-office procedures offer ENT surgeons a great opportunity to grow your practice. It also provides for a lot of personal, professional growth and development. So for the next few minutes, I'm going to describe how to deliver a peaceful in-office procedure. This is the American Society of Anesthesiologists classification of sedation levels. And the key point here is for these procedures, we really want to stay in this, there we go, in this minimal sedation classification or anxiolysis. Because once you start interfering with the airway or breathing or cardiovascular function, you need more monitoring, you need more training, you need more personnel, and basically you lose a lot of the efficiencies of doing something in the office. So there are a lot of different types of medication and combinations of medication that you can use for your oral sedation protocol, but in my opinion, benzodiazepines are probably the cornerstone. Diazepam or Valium has been around a long time, and in those earlier days when I was doing a lot of facial plastic procedures, we used Valium almost exclusively. The biggest problem, however, is that long half-life of 30 to 56 hours. So you'd have these patients who were sedated or confused the day after their procedure, which isn't great. At the end of the spectrum, triazolam can be used, but it has a really short half-life, perhaps too short. We tend to use a lot of lorazepam or Ativan, and the key thing here is the onset at 20 to 120 minutes. So it doesn't work that the patient comes in the office and you give them a pill and sit them down and start doing the procedure. We routinely have them take their Ativan 2 hours before the procedure, so then when they arrive with their caretaker, they're already sedated. And the half-life of 12 hours means they're going to be sedated but comfortable for the remainder of that afternoon and evening, which is fine because you don't want them doing anything. But then they're going to wake up and their head is going to be clear, and they're not going to have any hangover effect. The next class of sedation medication is narcotics. Common ones, of course, are hydrocodone and oxycodone. And I've used hydrocodone in the past, and you can use it with benzodiazepines, which I've also done. But there's that there's that risk when you mix benzos and narcotics of respiratory depression or having them slip into a deeper stage of sedation than you want. And of course, that risk is increased in patients with sleep apnea. So you can certainly use narcotics, but we've found for the most part that it's not necessary. And I think there's a lot of peace of mind for the doctors and patients and families nowadays when you avoid narcotics. There are also sedative hypnotics that are not benzodiazepines, like zolpidem or Ambien. And these have a rapid onset of action and a short half-life. So they seem to work well for sleeping pills. But sometimes if you're not asleep in your bed, I think there's sometimes a little more of the hypnotic effect than there is the sedative effect. And some of those patients get fairly confused. So beta blockers can be useful to decrease bleeding and lower anxiety and provide some sedation as well. I don't have personal experience using these for office procedures, but it's certainly an option. Similarly, alpha-2 agonists can decrease blood pressure and result in some sedation. And in this class, I do have a lot of experience. I fairly routinely use clonidine along with a benzodiazepine in combination. So topical anesthesia is really important, and you need to use a combination of an anesthetic agent and a vasoconstrictive agent. Cocaine used to be used for both of these options, but I think there's so many hassles and expenses with it that most people have moved away from it. Ponticaine or tetracaine or lidocaine can be used in solution or gel form. And I've used the gels before, but they get a little messy. And if that gel slips down in the back of the nasopharynx, it can cause the throat to feel numb and patients feel like they can't swallow. So I typically use lidocaine solution, 4%, mixed with epinephrine, although some people mix it with Afrin and seem to do well. And then I use it on neuropathies. Yeah, the 1 milligram per ml. So on the right, that injecting gel, you can just insert gel in every location that you want to have anesthetized, and it's technically easy to do, and it's pretty cheap and quick, but it's messier, and I just don't think it's as good as placing pledgets in the exact places you want. We found that placing pledgets using an endoscope and a small alligator-type forceps precisely in areas that you want to decongest and anesthetize is the way to go. We use little 1 by 2 centimeter pledgets. Sometimes those longer ones, the 1 by 4s, you can't get them into the middle meatus, or you're trying to get them back to the sphenoid. They're just a little long. And those little 1 by 1s are fine, but you have to put so many of them in, and then you got all these strings coming out of the nose. Just little things. And you can have yourself or an assistant place the pledgets. And here's the key thing is first, you just have them place it in the anterior nose, right up against the septum, against the inferior turbinate. If you can slide one a little medial to the middle turbinate, great. If you can slide one a little bit into the middle meatus, great. And then you leave them for 5 or 10 minutes. So now you've got the front part of the nose anesthetized. Then I come back and using an endoscope again, and I usually use a little ear curette, I push the pledgets into the exact spot I want. So if I'm going to do a maxillary sinus balloon, I'll push it in and even try to get it behind the uncinate. Sometimes you can even scoot it into the hiatus semilunaris, or at least up against that ethmoid bulla, and then you leave it for another 5 minutes. Similarly, if I'm going to do a sphenoid, I take that first one that's just medial to the middle turbinate, and then I push it slowly all the way back, sometimes in a few little segments, push it all the way back to that superior turbinate or the anterior wall of the sphenoid, and then maybe put another one behind it. So that first part is just putting the pledgets in, getting things generally numb, and then putting them deeper and more precisely. And then once you've got your oral sedation and your topical anesthesia, injecting local anesthesia is really just kind of icing on the cake. I use it very sparingly and in small amounts, and I know Dr. Scarata, who's got more experience with this than I do, uses injection rarely, if ever, and maybe you can comment on that in the end. But if you do inject, here are a few little pearls. Firstly, inject areas only that have been anesthetized topically, so don't go in and inject first. There are some special needles, like the RAND, the reinforced anesthesia needle. It's like long and rigid, has a little hub at the end so you don't inject too deeply. It's got a nice little angle. So for instance, if you're doing Eustachian tube balloon and you want to inject the torus tubaris, the spinal needles tend to be too flimsy, and a standard 27 gauge needle is not long enough. So like those RAND needles are nice because you can get them back and then inject right into the torus if you need to. If you're injecting anywhere and some squirts out and finds its way back to the nasopharynx, it can literally and figuratively sour the experience. It just tastes bad in the back of the throat, and then they get that same thing of their throat feels numb and they can't swallow. And finally, whenever you're injecting, you always have to be aware of the maximum dosage of lidocaine. But if you're doing an in-office nasal procedure or sinus procedure or Eustachian tube balloon dilation, and you're hitting those maximum doses, you're doing something wrong. A few other tips when you're doing in-office procedures. The ambiance is very important. You want it to be quiet. You don't want people coming in and out of the room or talking loudly. We put on soft music, usually either spa music or classical music. That seems to be best. And then we use these soft, comfortable eye shields, which not only protect the eyes, but also add to the sensory deprivation and this relaxation. The next two terms were used frequently by my old partner, Dr. Maggie, who, I don't know if anybody here even remembers him, but he's 92 now. And I just saw him a few weeks ago, and he had this great Estonian accent. And if I was doing something like packing a nose or something, he'd go, just give it a tincture of time and use some verbal anesthesia. He also would follow that up with, God damn it, Waterman, you're a slow learner, but you'll get there someday. So,
let's hope.
Yeah, right. Still working on that journey. Anyway, the point is, don't rush the process, especially the topical anesthesia, and speak reassuringly both before and during the procedure. And a big tip is that this is all about the patient journey, so that setting them up for an office procedure starts at the consult. So you're saying, we can do this in the office without a trip to the hospital or the operating room, and we'll keep you comfortable, and we do this all the time. And then at the pre-op, you're talking in a little more detail about the sedation medications. And then during the prep, you're again starting with pledgets only in the front part of the nose, and then gradually putting them back, and then maybe some injections. And all these little things can add up to a very smooth patient experience. So some pearls for the hesitant patient. A lot of this has to do with communication. So starting at the pre-op, you want to explain the pre-op medications or the oral sedation medications in detail. I usually say, we're going to give you one pill that's going to make you less anxious, and then another pill that's going to lower your blood pressure and make you a little more drowsy. And that combination works really well to make you comfortable. When describing the topical anesthesia, I don't say stuff like, I'm going to shove some neuropatties up your nose. We use terms like, I'm going to move little sponges around, and every area that the sponge touches becomes comfortable. See the difference there, right? And it can really be helpful to downplay the anesthesia injections. I usually don't use the word needle or inject. I just say sometimes I put additional numbing medicine, but I only put it in an area that's already at least partially numb. And then finally, you want to reassure them that they won't lose control. I think some people think that they might be in pain, but they're so out of it that they can't express it. Like, what a terrible feeling to be in, right? But you tell them, if something hurts, you just say, ouch. And if you say, ouch, I'll say, sorry, let me make that a little more numb, and we move on. Another trick I learned from Dr. Scarata, and I was watching him a few years ago, and he had done hundreds, thousands of these. And we were doing a procedure, and the patient was a little uncomfortable. And he said, well, I can stop right here. We can come back another day, or you go to the operating room. We don't have to finish this. And I was like, oh, you can't say that. And of course, the patient said, no, 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 keep going. That's fine. And I've used that a couple of times over the last couple of years, just saying, are you okay? You want me to stop? And invariably, they will say, no, no, keep going. But then they just feel like they're in control. It's just nice to know that they're not in something and they can't get out of it. So some tips on keeping the whole process safe. You want to have a protocol for the caregiver so that they understand that the patient is going to be sedated when they bring them to your office, and they're going to be sedated when you get them home, and also that they have to stay with them during the afternoon and evening, just for safety things, that they don't go in the kitchen and turn on the stove and, linger by the door when they go to the bathroom, that kind of thing. Creating written protocols and action plans is critical for safety and for medical legal purposes. Then after the procedure, don't rush the patient out the door. Make sure you get a final set of vitals and a final assessment of their level of consciousness. And although I've talked about what we typically do, you really want to tailor your anesthesia treatment. And at first I saw that typo there, and I was like, oh, I should correct that. I'm like, no, because I'm going to shout out to Taylor Backus, Doug's oldest son. So that's what that's about. So you want to tailor your anesthesia to each patient. Some require more and some require less. And then go and learn something new and have fun as you create a great experience for your patients. If you decide to embrace the concept of in-office nasal and Eustachian tube procedures, here are a few tips. Start simple, select your patients carefully, build a team and build the processes, invest in technology and equipment, and then go and transform your practice. We've got a few minutes left, and I would like to have Dr. Scarata give just a few of his insights or comments, and then we'll open it up to some questions for either or both of us. So you can come on up here, Doug. See, I'm like a podium guy. He's like the wireless mic guy.
I would love to meet any of you all. If I came up here from Salem, I set my alarm clock for 5 a.m. and it was 5 p.m., so I slept in. I was a little bit late. Thank you, but if any of you all will come up and say hi to me in between things, it's the whole point of coming here is to meet some people. I know the people from Oregon, but not so much from Washington. So, yeah, I mean, if any of you guys are wondering whether or not this is worth it, it is totally worth it. And if any of you want to talk more about it, just talk to us about it separate from this. This is not meant to be overwhelming. This is meant to just be, there is no one perfect way to do it. There really isn't, And I don't know how much time we have, but I would say that my one pearl would be this, is that when I started this whole thing, I thought about the golden rule, which is do unto others as you have done unto yourself, is wrong. Don't do that. Do the platinum rule. The platinum rule is do unto others as they shall have done unto themselves. And this makes that point better than anything else. I thought, if I was having this done, put me out. I want to be oblivious. You just do your thing. I trust you. And then I want to wake up. But it turns out there's a lot of patients who don't feel that way. And we could tell stories about that. But so we created a process where some people want to be particularly light, and that's fine. Some people want to be asleep. That's fine. And the last thing to share is that the last thing I say often is bad, evil doctor. Whenever something, they go, whatever, I say that, and then they chuckle, and they know I'm not really bad and evil. Am I? No. Thank you, guys.
So thank you, Eric. So you certainly chat with them. I think